Certainly. Sound 1, 2, 3. Checking 1, 2, 3.
Anyway, does the mic sound like oh, here we go. Perfect. Okay. Hello, everyone. Thank you for joining us in today's session on COVID case studies. My name is Trina Jones, and I'll be the facilitator for today. I'm the CEO of Homelessness New South Wales. Before we begin, I would like to acknowledge the land on which we meet today, the land of the Ngunnawal people, and pay my respects to elders past, present, and emerging. The onset of COVID-19 created shockwaves across the world, resulting in significant loss of life, lasting economic impacts, and the social impacts that will be felt for years to come. All of us, endured lockdowns, uncertainty, illness of family members, and ongoing challenges in the delivery of our services. The case studies that we're going to hear from today give us an opportunity to pause and reflect. In our practice, it's the old adage comes to mind, never waste a crisis. And I think what we saw through COVID was the opportunity for the evidence base to meet innovation. And that resulted in significant outcomes for people that were street sleeping and others that needed support through that process. And actually, if you look at some of the evidence in the short period of time, the most people ever were housed, in many ways through COVID because of that evidence base existing, the will of the sector to come together in that challenging time, and also the investment for innovation. So what is really going to be an opportunity for us as a group, and we're a small group, so I think we can make this quite interactive, is to draw upon our reflective practice skills today. Listen to, some of the learnings from our fabulous panel, and then have an open discussion as a group about, with the panel and with the people here, about what are the lessons learned and what can we put in place to better position us for the future, and where are the gaps and how can we fill them so that we don't have to have that same scramble and stress and pressure, and that we can actually build the resilience in, because the resilience is not the delivery of the service, the resilience is how you bounce back, right? So really looking forward to hearing from the panel today, and I would like to introduce Launch Housing and Mind to kick us off to talk about the innovations. Thank you.
Thanks, Trina, and good morning, everyone. I'm Tanya Armstrong from Launch Housing. My role at Launch is as General Manager of Keeping Housing, which is one of two general managers overseeing all of our client services at Launch. We're an agency that delivers the whole spectrum of services and is a community housing provider as well, with about 400 staff. But disclaimer, I'm actually not in my role at the moment. I've been on extended leave, and those in the room who know me know I'm living in Bali at the moment. So we're going to talk about some of the COVID silver linings here. Having a break and Launch allowing me to take that break has certain lining, so I'm very appreciative of that. But it means I'm a little bit rusty as well. So this is going to be our reflections of the, and I'll introduce Mind as we go on, but Emilio will speak after me, and Mark Heeney will speak at the end as well. Mind are our partners in the program that was conceptualised during COVID. So I'm going to start with a little bit of context, because for those of you who are not Victorian in the room, maybe won't have an understanding of the scale of the task that confronted us during COVID. And I haven't got a lapel, so every time I step away from the microphone, it's going to go silent. So I'll try and stand in one spot. It was a rapid response by the Victorian government. Sorry, we're running two screens here. But it's not moving on this screen, so I can see the notes. Yeah, but it's not changing on the screen, so I can see the notes. I can just talk to the slides. So congratulations to the Victorian government. I can't see anyone from Homes Victoria in here today, but they were amazing we've just heard in that session, delayed responses from government, but in this case, it was rapid. Within weeks of COVID hitting Melbourne and the state of emergency being called on the 16th of March, $6 million was provided to the homelessness service sector as an initial injection to support people into hotels. And at launch, we're the assertive outreach service on the streets in Melbourne. So all of our resources were diverted to finding people and putting them in hotels. And you heard Ben Rimar talk on Monday about the enormous task statewide that was. So from our perspective as a service provider, it was enormous, and there was lots of other service providers that also undertook that enormous task at the same time as all of our staff were feeling pretty anxious about what was to come as well. So that Ben talked about the peak in July 2020 across the state being 8,000 people, and at one point in time 3,200 people in hotels. From launch's perspective at that time, we were holding 1,630 people. So it was just an enormous scale of people. And, you know, we're used to working with this highly complex group, but not at that scale. So it was, I don't want to use the word unprecedented. I promised myself I wouldn't say that once. But it was a concentration of really high needs in the hotels. Of those 3,000 people, 75% metro, 25% in regional areas. In the local government area of the city of Melbourne alone, there were 10 hotels with, you know, over 50 people in each of them. In one hotel, we had 130 people. So highly volatile environment most of the time, very unpredictable, both for staff and for clients.
Thank you.
And during that time, we were continuing to do all of our initial assessment and planning. Our entry points, which is the front end of the service system in Victoria, those staff were essentially becoming hotel booking agents, but they were constantly on the phone trying to complete initial assessment and planning forms. And so that information was really invaluable in telling us who was in hotels and where we needed to direct our services. And there was an assertion at one point in time throughout some of those lockdowns that people were taking advantage of the free hotel accommodation, moving out of private rental and picking up a hotel room. But our data showed us that that absolutely wasn't the case. And the average of the people we had at that peak in July 2020, the average length of time since their first contact with launch was 8 years and 3 months. So you could assume that's 8 years of housing instability very conservatively, because that's only our service. They could have contacted other services. So highly complex group of people, 90% of people identified as having either high needs or medium needs. So no access to other forms of housing. Same with vulnerability. So high risk of harm to either themselves or others, and absolutely no other support safety nets. And so what that meant is that we all in the sector needed to redirect our services like many of the other states did, but this was a scale that nobody had seen before. So it resulted in enormous collaboration across the sector, and this was an amazing time to be a part of it. We were all, for once, directing our energy into one spot rather than, you know, being dispersed everywhere. We were the conduit for all of those ancillary services and other disciplines to those clients who were previously dispersed in the community, but now we knew where they were, so we could direct our efforts to those who were most vulnerable. And at that time, we were also standing up newly funded services like the SURFs that Ben talked about, and the homelessness emergency response teams, which were essentially concierge services trying to provide support to people in hotels. But, you know, navigating the support was really logistically difficult. So what they essentially became was incident managers. So really difficult time for lots of our staff. And, you know, other services like material aid, at one point we were helping to coordinate the delivery of 700 meals a day to people in hotels right across Metro Melbourne. So it was enormous. And the data that we collected at this time, I mean, it was torture for us to respond to government's request to data, and I can see Ruth smiling there. But it was so invaluable, and Ben talked about that data-driven response, and it's true, it was a data-driven response. Homes Victoria were using the Victorian Data Linkage Service to link the data the sector was providing with government data in health and human services and justice services. and they were able to link 80% of people. And what that showed is that in comparison to a group of people who had accessed services in 2019, these people had higher use of mental health, alcohol and other drug and family violence services. So government knew this was a really highly complex group of people, and it was more than we'd ever seen before from previous street counts. So I think at one point we were saying 6 times the number of people that had previously been counted. So same as other states, that it had just uncovered this historical undercounting of people. But that data, I have no doubt, informed the design of the program for homelessness to a home, from homelessness to a home, which you've probably all heard a little bit about here already. But it was a bit like utopia for us, really. We were pretty thrilled to have a program that was deliberately designed to provide at least 2 years of support for people, that was connected to housing, was pretty amazing. So we had really high expectations of ourselves. Government had enormous expectations on themselves. It was the Premier, Daniel Andrews himself, who announced the program. So it was widely known in the public domain as well. So yeah, feeling the pressure we were just a little bit, and just the scale that we, and the assertion that this would address rough sleeping in Melbourne CBD. Lots of pressure, enormously ambitious timelines to get it going as well, not without its challenges, and we're going to talk about some of those as well. But just a quick snapshot is 2 streams of support, both funded in different ways, which reflects the different caseloads of the staff and the multidisciplines. So yeah, people in the intensive support stream have access to other services as well. 3 types of housing arrangements, and housing was by far the biggest challenge in this program. Public housing, existing public housing managed by Homes Victoria, head lease housing, which H2h providers leased in the private market and then managed, and general lease housing, which was government owned and spot purchased at that time, but that was where most of our challenges were and continue to be in that time limited housing. So based on housing first principles, but of course limited fidelity to that model because it is a time limited program, and the housing, apart from the public housing, is time limited as well. So Launch immediately collaborated with our close friend Mind Australia, and together we collaboratively I guess, designed a consortium response that would meet the needs of the people we knew would be coming into the program. So we were soon joined by Uniting, AOD specialist practitioners, Bolton Clark, who are previously the Royal District Nursing Service in Melbourne, so community health nurses who we already work with in lots of our programs and are invaluable in engagement with people who have really complex needs, and particularly around their primary health needs. And VACSEL, the Victorian Aboriginal Community Controlled Organisation, to provide direct case management for Aboriginal people. You heard Ben talk about, a high proportion of Aboriginal people in this program, and CoHealth. So between VACSEL, CoHealth and Launch, we are the case managers, case coordinators. So we're all learning from each other from those different organisations, and then specialist psychosocial support from Mind Australia, Uniting's AOD support, and the community health nurse. So a fabulous consortium to be a part of. And any questions you've got about what's working in the consortium and what's not, but we're all very values aligned. It's really refreshing to work with organisations like mine where they share the same client focus that we do. So that is the base from which we work, and trusted relationships, and just an enormous amount of goodwill from our partners. We want this to work. And before I hand over to Emilio, a quick note about the governance structure. So 3 levels. We designed this as part of our tender response, and The governance and steering committee is responsible at that high-level decision-making, of course, and, you know, contract management. We've kept some of the contracts open throughout the period of the program to try to remain agile about what clients need. Below that sits the Operational Service Development Integration Committee, which, you know, as the name suggests, it's about integrating our services, making sure we're operating from a consistent base and that we're working well together. That group also looks at data and reporting and is, I guess, continuously aiming for improvements to the program as we've gone along. And then the Integrated Case Management Panel, which focuses on so specialist clinicians from each organisation across all the disciplines, focusing on our most complex clients and looking at ways to address service system gaps and barriers to them engaging in services. So I'm going to hand over to Emilio, who's been the service manager in the program from Mind's perspective, and he's going to give a little bit of detail about the program on the ground, working within the teams.
Okay. Hi everyone, I am Emilio, I'm from Mind, I'm the service manager of the Mind team. It's been a privilege to be part of this program, I think. Maybe one in a lifetime kind of opportunity to try and do our best to make a difference to end homelessness or get close to it, at least for a period of time. Yeah, I think what Tanya was saying there is very resonating with me about the consortium collaboration that we've been able to work in. And all the consortium partners, from my perspective, sort of, you know, work on the ground, support the staff that work on the ground. And I've been able to see how that translates into reality. All those values, all those practice principles that we all talk about as organizations, seeing them in everyday practice. Person-centered, recovery-oriented, culturally safe and inclusive and trauma-informed practice. But I guess also how do we share a space where different organizations with different policies, procedures, different ways of recording data can work together and speak the same language. So some of the things are listed there. We've got a database that we all use. We all write case notes in the same place. The information doesn't get lost within the consortium. It's all in one place. Documents are uploaded there. There's a service prioritization decision assistance tool, SPIDAT, that we use to assess needs, to measure outcomes as well. We all work on the same support care plan that is on that database, and each member of the different partner agencies can modify those documents, and everybody's on the same page. I think that's saying the same thing that I just said, but yes, it's all stored safely in a secure data facility in Victoria. There's also some tools that are specific to each organization, each partner agency. For example, we've got the My Better Life tool at Mind. The interesting thing is that what we've learned is that a lot of those tools overlap with each other. So what do we do to avoid duplication, to avoid bombarding poor clients with the same kind of conversations? And we've learned to speak one language, even if we come from different places and different organizations. So the SPIDAT domains correspond to the My Better Life areas somehow. So it's a matter of agreeing on what language are we speaking. Okay, so we've got a lead agency. Lead agency chose to use the SPIDAT. What do we know about SPIDAT, about that language? Not much. Okay, we need to learn. And the best way is to create a bit of a dictionary there. I'm not going to go through all the details of all the different areas, but again, feel free to ask questions at the end. There's a few slides there. Social relationships and networks, spirit domain corresponds to 2 different areas that are covered on the My Better Life. Some of those are more detailed in My Better Life, some of those are more detailed in Spirit. It doesn't matter. It doesn't matter what language we speak as long as we actually understand each other and our clients understand us, so that we can understand them. So I'm just gonna be very mindful of time and skip through those, but get to this part that I'm very keen on, which is the co-design practice. So there's 2 examples that I'm going to go through quickly. One is the My Transition Toolbox, and one is the H2h Client Support Group. We chose those 2 because of the co-design model that we've used. This is the model. We actually used a model that is called Co-Design Lab from Auckland, and it's 4 different phases of, some of you may already have heard of that, but yeah, there's different 4 diamonds with different phases of engaging with that process. Frame and engage, explore and connect, imagine and create, make and test. So I'm just gonna, no, didn't want to do that, sorry. Go back and use my paper instead. I got some notes there because I guess that, it's quite a simple process. However, the way that it translated in reality was that there were a lot of people involved in this process. The frame and engage phase was when a project working group was created. It was made of general managers and mine, as well as service managers from this consortium and other consortiums that work in H2H in other regions. Peer support workers, we tapped into different resources within the consortium, Aboriginal specific case managers from Baxal as well. They helped out with that. The frame and engage phase was when we sort of asked ourselves some questions. How can we support clients to transition out of H2H, being a limited time program? And what do they need? And how can we support them in the best way possible? And during that phase, we consulted research, we consulted, the literature or on other services in mental health, homelessness that transitioned people out, what worked well in that space. But we also consulted with the staff and with the peer practitioners, Aboriginal workers, and most importantly, clients that were currently engaged in the program to learn from them what they needed. That's what happened in the Explore and Connect phase, different workshops with different people, paid participation opportunities for clients, huge effort, but very, very valuable and very important to do for us to understand their needs. The Imagine and Create phase was when we started to put things together, and we created 3 different documents. One was the My Transition Toolbox, one was a bit of a manual on how to use it to support staff with practice tips. I think I've got, got the, how that looks like. It's very small, but there's, but it's very simple. It's just 2 pages or 1 page on 2 sides. And it's just blank boxes where people can write the support networks that they have, the things that are going to work to support them. And it can be used on paper when you have a conversation with clients. It can be put aside completely if paper is a barrier, and then just used to note those things so that there is a final product that can be used by clients moving forward. But the make and test phase was Also very important because we reviewed what we did, and that's when we engaged with the various peer practitioners and Aboriginal workers who gave some feedback on the guidelines, I guess pointing out some important things that would make them more accessible, more culturally safe, and also I guess easier to understand from a client's perspective. So, and the H2h Support Group was another similar, same 4 diamonds or 4 phases, similar process where we created this 8 sessions support group with different topics that are listed there that resonated with clients. There were opportunities to get information about those topics, but mainly it was an opportunity for people to create a sense of community. These are very vulnerable people that have experienced homelessness for an average of, 10 years, and an average of 10 years, rough sleeping, and they get together and they experience challenges moving into a home and finding that, you know, they're actually used to having a home that we, you know, don't necessarily connect with, you know, on the street or, being homeless for such a long time, that's their home. So they move into a home and they adjust and they experience a lot of the challenges. They get together. We don't understand those challenges necessarily, but they do, and they support each other. We didn't have a lot of attendance because a lot of people, you know, were not ready. A lot of people dropped out, but we had this few that really connected with each other and brought, you know, I guess a sense of community to life. And again, the process was very similar in terms of how to get to the final product of what we are offering. And we are planning to offer it again, I guess, in the next future, giving also the opportunity to one of the participants to co-facilitate the group this time. So another paid participation opportunity. Now, that's a bit of a case study. I'm not going to remember all the details without the notes, but I'll consult my paper again, like I'm organized. Yes, so SK, 38-year-old male, long history of homelessness, spent most of his life in prison, most of his adult life in prison, more time in prison than in the community. I guess a lot of different little bits and pieces of examples of strengths that, you know, he was bringing in the work that he was doing with us. Things like connection to family, 2 daughters that he was very supportive towards. Great cook. I guess some possibilities of expanding meaningful ways of engaging in those kind of activities. I guess the outcome was that in the 2 years that, or, you know, close to 2 years that we've been working together, he was not incarcerated. And that's the longest period of time during his adult life. But how did we get there? So the support provided there, obviously secure housing was key, because for the first time, he would actually have a home that would provide stability. And then different parts of the consortium, different agencies provided different kind of supports. Lunch housing providing case management and care coordination, and support around housing, maintaining the tenancy, support with court hearings, pest control, because there were bed bugs, and that was a challenge. And Uniting providing support for drug addiction, which was one of the main barriers. And Minds providing support to develop strategies around managing emotions, emotional regulation, anger management, and just talking through issues that come up every day. And support getting to appointments, assisting with the application to the NDIS, which hopefully is going to be a pathway for him to be supported in the longer term after H2H wraps up. And then, yeah, supporting getting his learners, because driving was going to be very important for his independency and connection with family. I'm just gonna invite Mark to the mic. But yeah, I was very quick in running through different things. So if you have any questions, please ask in the end, but all to Mark.
Thanks so much, Emilio, and I will be quick, I promise, because I'm very excited to hand over to our sector colleagues to hear about their program as well. So some of our challenges and where we are at right now, there's 420 packages that have been serviced and 449 clients. That increase is due to some people that have moved on, and extremely tragically over the course of this program, 15 clients that we've been supporting have sadly passed away. That sort of really highlights the complexity of the lives that people lived for such a long period of time. And often we found that a lot of those deaths were due to drug overdose as well. The average length of homelessness, we've talked through that as well. That 84% of individuals having a dual diagnosis, that covers the tailored and targeted and the intensive supports. If we were just to look at the intensive supports, we feel as though that would be much closer to around 95%. So that dual diagnosis for our consortium was a significant factor in the program of supports that we were delivering. And probably not surprisingly to people in the room and people online, that the experiences of family violence were significantly high as well as significant levels of comorbidity. So not just mental health and drug and alcohol issues, but significant physical health issues that people had been living with for a long period of time. I think before I sort of jump into some of the learnings, it's important to note that this is one view of one consortium that was delivering homelessness to home in Victoria. There were multiple consortium that were delivering across the state. Our program focused on around inner metro Melbourne, stretching out to the Mornington Peninsula as well. And I think when the evaluation actually occurs, and Ahuri have been appointed to do the evaluation, it'll be extremely interesting to see the differences in outcomes based on the different consortium that are actually built. So ours, again, was extremely focused on having a multidisciplinary response that comes with a level of complexity of working within a multidisciplinary team, as well as being able to work out when those different supports were needed to be delivered at a particular time as well. So that was certainly a benefit for us of actually having all of those organisations involved. Timelines were really tight and tricky to manage, as Tanya highlighted earlier on, particularly around the expectation of getting people out of hotels and into housing as well. And also, which often happens, how people present on paper of when those initial assessments are compared to what their actual support needs are often chalk and cheese. And that obviously was a good opportunity for us of having that multidisciplinary approach to then actually redo a lot of those assessments as well. And those inconsistencies around great intention of going out and doing spot purchasing from Homes Victoria, probably not the greatest amount of research or homework that was done to actually understand if they were in the right communities, and that consultation had occurred as well. That community acceptance, really important for anybody thinking about in the future. I'm sure there will be more pandemics in our lifetime, but around engaging with community, understanding who the community is, understanding who your neighbours are, just will do worlds of wonders of actually being able to demystify stigma. There's so much stigma associated with people that have been experiencing chronic homelessness for a long period of time. And we found, particularly with our stakeholder engagement toolkit, that worked wonders. But if we had our time again, we certainly would have done a lot of that engagement earlier on as well, as I think Homes Vic probably would have as well, particularly around when thinking about where houses were to be purchased as well. That speed and scale, as well as being able to respond to individual client needs. Of course, within social services sector, we often think that caseloads are too high. But that was a big issue as well, of being able to respond to need when somebody needed it as well. We talked earlier on around, like, this model is certainly not for everybody. Some people's level of complexity requires more than just some support during the week. The Common Ground model, I think, is a really great example of where people who do require that 24/7 support can actually be a much more suitable model for some people as well. I think that's an important lesson for us as we think about the future as well. And then some of our other learnings as a consortium, of course, around managing processes, engaging. NDIS, I think, is a really key factor as to what long-term support will be. We're still quite concerned as to where the sustainability of this funding will actually get to. The sector, led by the Council for Homeless Persons, specifically through Jenny Smith, did some wonderful advocacy to ensure that there could be an extension of funding. But a lot of anxiety was, I guess, provoked amongst clients and even staff as to thinking, am I still going to have a job because I know this funding is running out? And I think that's still an important factor around that long-term certainty helps to keep a very consistent workforce, but also helps to ensure that people that are receiving the service have that continuity of support and care as well. But with NDIS, always has been an extremely tricky population to engage for the NDIS and the NDIA specifically. I think in future, and even now, having that ongoing engagement with the NDIS to be able to have specific pathways. So there is LACs and planners actually going out to people, meeting them within their environments, being a little bit flexible around making sure they don't need to have all of the identification that you require and the eligibility. So there's certainly, I guess, a lot of more collaboration across into the disability sector, into the Commonwealth, that needs to occur in future as well. It's a very quick snapshot as to where we currently are. With 382 clients are currently sustaining tenancies. Those head lease stats, we're pleased that although some people's head lease has not sustained, after actually supporting people into a second tenancy, into more appropriate housing, has actually found that it has been much more successful as well. And 81% has sustained for 9 or more months. And there are still a handful of clients that are still not housed. So that's still something that is an important part that for us to continue to work with HomeSvic to ensure that we can find that appropriate housing as well. Some of the key points, I won't repeat a lot of this. This is mainly around the importance of multidisciplinary support, the importance of really matching individuals to housing types, importance of community and how you build community and doing that engagement, and recognising that AOD and mental health support, although Mind are a community psychosocial provider, engaging with clinical mental health services was not always easy, and that, I guess, is something that we would like to consider in future, as well as to how to really bring in and engage clinical mental health services much more closely as well. That's all. So thank you. I'll now hand over.
Thank you. Thanks so much. Like, that was, I'm really looking forward to being able to get into some of the questions. We might just hear from the next presentation, and then we'll go to some questions for the whole panel. So next, I'd like to please introduce the Sydney Rough Sleeping COVID-19 Task Force. And this group represents the Inner Sydney response to street to home programs through COVID-19. So thanks very much, guys. Thank you. Yes, is Penny on? Just to let everyone know.
Hello.
Great.
The powers of the virtual world. It's wonderful. Hello, my name's Penny Church, and I'm representing the New South Wales Department of Communities and Justice. And I'm here with my colleagues, Shane Jakupec from Neami National, Erin Longbottom from St Vincent's Homeless Health Service, and Tasmin Knight, also from the Department of Communities and Justice. And I'm very sorry I can't be there today, but COVID hit me on the weekend and I thought I should stay away. We'd like to acknowledge the beautiful land of the Ngunnawal people, the traditional custodians of the land that the conference is meeting on. And I'd also like to acknowledge the beautiful land of the Gadigal people of the Eora Nation, where I live and work. We pay our respects to all elders, past, present, and those emerging, and all Aboriginal colleagues who are in the physical and virtual room today. As we've just heard from Victoria, COVID-19 has required governments and non-government agencies to react and respond differently to people sleeping rough. We and other sector partners work together to respond quickly to provide support to people sleeping rough in the Sydney CBD and to ensure they and those who are working with them face-to-face remain safe and healthy during COVID-19. We're here today to share our collective experiences. Next slide, please, Tamsin. In this presentation, we'll talk about the early days of COVID-19 in New South Wales and the early establishment of a task force to facilitate problem solving and decision making in inner city Sydney. We'll briefly provide information about the activities we quickly scaled up and adapting policies to better respond to emerging needs. We'll talk about our achievements and our lessons learned. Next slide, thanks. Now, as you'll remember, the first infection of COVID-19 was reported in December 2019, and by the end of January, the first cases were being reported in Australia. At the same time, the City of Sydney February 2020 street count found 334 people sleeping rough in the local government area. Inner city Sydney has the largest concentration of people sleeping rough in New South Wales and is a high draw card for people. For those of us working with these people in the CBD, we recognise that this cohort of people were vulnerable to COVID-19, were more vulnerable to COVID-19 than the general population. And this was due to a higher incidence of chronic disease, decreased immune function, and mental health and substance use comorbidities. The complex nature of many people's health conditions on top of sleeping rough would likely impact their ability to practice physical distancing and respiratory hygiene. There was a very strong base of collaboration in the Sydney local government area, and this enabled us to mobilise quickly to respond to this pandemic. We've been strengthening our partnerships between homelessness services, government and local government services since 2015, and we're no longer working in silos. The urgency and scale of the public health response required significant additional resources and a major expansion of the existing collaboration and coordination. We needed collaboration on steroids. Next slide, please, Tamsin. When the first COVID-19 positive case was identified in New South Wales, the local partners realised quickly that we needed to ramp up our collaborative approach. The Department of Communities and Justice floated the establishment of a task force involving all key stakeholders and based on international evidence, and we drafted a terms of reference in mid-March 2020. Such was the commitment of all agencies that senior representatives made themselves available, and the task force was stood up within the week. The Sydney Rough Sleeping COVID-19 Task Force, a cross-sectoral task force, brought together non-government organisations, state and local government, to engage with people sleeping rough and provide safe accommodation with health and welfare support wrapped around. It also worked to assist SHS providers to manage COVID-19 outbreaks, including the deconcentration of large crisis accommodation sites. Membership of the task force was inclusive. The task force met weekly, which reflected the commitment of agencies and listened to regular reports from services on the street. It was a safe space for issues to be identified, and the task force worked nimbly to problem solve and respond to emerging needs. The task force formed several working groups to tackle practical issues as they arose. These working groups were able to focus collective efforts to better support people accommodated in the hotels. Working groups were established as and when the need arose. For example, with a large number of people going into temporary accommodation and physical restrictions limiting access to food services, we quickly realised the need to have meals delivered directly to people. We engaged with parliamentary kitchens who offered to provide packaged cooked food, and Oz Harvest, who delivered it to the hotels. Aboriginal Task Force members identified the need to provide culturally appropriate responses to Aboriginal people and communities sleeping rough, so an Aboriginal Homelessness Coordination Group was established. As outreach workers began telling us about the specific needs of people with pets, a working group was formed to find hotels willing to accept pets and gain access to pet foods and get pet supplies. Because supports were established or scaled up at considerable speed, policy and practice barriers quickly became evident. However, they could be fed up in real time through the task force and then addressed in a continuous learning loop. And the task force had the authority to develop the required responses. This was because it had commitment at a high level from all agencies. It was chaired by the department's local district director, the most senior departmental representative in the local area, and supported by the directors who managed the commissioning of services and housing operations. It reported to the department's deputy secretary, and the minister's office attended the meetings. Each agency was represented by a senior officer or manager, supporting the ability for all agencies to make decisions and carry out direct actions. The task force endorsed a plan for the delivery of accommodation and health support for people sleeping rough. This plan was a dynamic source of truth. It was referred to and updated as new information or processes were identified. A key learning was that the strong leadership was pivotal. Leadership and coordination was provided by the Department of Communities and Justice, but it could not have had as much impact if the senior officers of health services, local council, and non-government agencies were not equally committed. Next slide, please, Tamsin. We would learn very quickly the benefits of technology to support broad engagement of senior people in weekly meetings. This photo depicts one of several pages of the Task Force WebEx meetings. I'll now hand over to Shane, who'll talk to you about the activities of the Task Force.
During that period, and I'll talk through a couple of the key things that we stepped up. So assertive outreach was already occurring in the city, but the activities were expanded to support people sleeping rough in the inner city to get them into temporary accommodation. So that was a key thing to manage the public health risks. 3 patrols were conducted daily in the CBD by the Department of Communities and Justice, health partners and homelessness service providers. These included in the evenings, and daily coordination meetings were established. And outreach coordination meetings in the CBD still actually occurred to this day on a fortnightly, bi-weekly basis. We developed a COVID-19 screening tool. The Erin and the Homeless Health Service worked to support all frontline and outreach services around this. The tool also supported homelessness outreach services to identify who to send for testing and why to do that. So as with other cities, the department began engaging with hotels impacted by the public health orders in March 2020 and was able to pre-book 380 temporary accommodation beds for 3 months with 22 different accommodation providers in metropolitan Sydney. Some examples of, policy change that had to happen through that feedback loop that Penny talked about included things like waiving the requirement of certain documents to prove identity and that you needed support. Also, the requirement for an upfront medical assessment to access housing for people in priority housing was waived as well, because in isolation to get people to medical practitioners was just a really tricky space. So in 9 of the hotels that were being utilised across the city, 9 of the key hotels, pop-up hubs were created. They were operated by health staff, housing staff, and Neami, the agency I work for. We were coordinating the rosters in the pop-up. With the assistance of the hotels and through these pop-ups, daily assistance was provided to assist with housing, social needs, and health services. A roster system was established to ensure the pop-up hubs were rotating between all 9 hotels. A suitable location would be identified in each hotel for this activity to occur, and at times there were challenges with that, not being able to find an adequate space and adequate ventilation, given the issues with COVID. As time went on, other agencies also began attending the pop-ups, bringing hot meals and clothes, supporting people with other needs. So people were provided with the temporary accommodation for as long as they needed. That was a key thing. It was initially a month, but as long as people were engaging with us to support them on their housing pathway, they were able to stay until they got another housing pathway, and it was really, really pivotal. Through the task force engagement, it became evident that also, as Penny mentioned, the large crisis accommodation facilities required, or congregant care facilities needed to be supported to move people into hotels as well, and money was made available to ensure that could happen as well, so people weren't in large groups. DCJ, or Department of Communities and Justice, also disseminated expert guidelines for specialist homelessness services on infection control, managing the mental health needs of staff and clients, managing service disruptions and considerations for vulnerable clients. These guidelines have continued and been regularly updated through COVID. Health also disseminated weekly bulletins which included regular health advice and updates on testing and vaccination. So flexibility and innovation led to new sustainable housing pathways as well. Additional accommodation exit options were identified, including reopening units on large estates or that were earmarked for redevelopment or meanwhile use services, and expediting turnover of transitional beds as well. So there's a lot of innovations there. So I just want to talk about one of the working groups now quickly. The support and accommodation working group was one of the ones stepped up, and I coordinated that one and pulled in a lot of amazing people to help with that because it was pretty intense. So the primary function of that was coordinating the support in the temporary accommodation with the rough sleepers that were there and other people that would come as well. And DCJ, they funded a new team within, or stepped up a specific team within their department called the START team. And they also funded 2 additional services, one being Neami and one being Inari, the Aboriginal agency, to increase capacity within the sector. So these teams worked with St Vincent's Health and DCJ and other homelessness services, to get people in the hotels supported, and also then supporting their pathways out into other accommodation. So some of the support and care coordination group that was stepped up, some of the key functions, I guess, of that group were we met initially weekly and then fortnightly. We were looking at coordinating the list of people entering hotel accommodation, ensuring a lead agency was identified with a support worker. That was really critical, so every client knew who they were working with. Developing consistent approaches to triage and needs assessment, as you guys talked about, that was a really important thing, and when everyone does their own thing, how do you know which tool to use? Overseeing and monitoring the provision of support to those in accommodation, including the healthcare, the mental health, the drug and alcohol support needs, daily living needs, social connection. Like a lot of people were requiring access to medications and things like that as well. So how that was all coordinated was managed through this group, and maintaining an up-to-date list of service capacity and staff availability capacity, including where additional staff may be required. I'm sure you all know people were isolating themselves, staff were isolating, people were getting COVID. So there was a big juggling act. So given the rapid pace and limited resources, what we did was we conducted a sector survey to identify workforce capacity, because many agencies stood down their teams or got them working from home or got them working differently. And we managed to get a lot of people to put their hands up and say, we've got staff that can be redeployed to do some of that case management work or some of the other work that was required to do the work effectively. So the NGO sector resources were redeployed from other funded program areas in response to the first wave. There was amazing goodwill with hundreds of staffing hours being offered, and I remember I had effectively an administrative person from the City of Sydney Council working to support us with the coordination group and the work that we were doing, and they were from some other department in planning or something, and so there was really great cross-sector work in that space. So people were, when they would come into the pop-up initially, so they're living in that hotel, and we would set up the pop-up downstairs. People would be health screened prior to broader engagement with the team. They'd meet an EMI staff member who'd work through identifying their immediate needs, and then they'd be passed on to a DCJ team member who would then work through their housing status needs. And it was effectively a one-stop shop, and that key worker was allocated to make sure that there was the case management capacity for all of the complexities that were there. Brokerage was made available to provide mobile phones and food vouchers. Getting in contact with people was tricky at times. Like, we received a list from DCJ of everyone that was placed in accommodation across the state. And most of the time people didn't have a phone. And so having a rotating location where people are aware that there's going to be staff on site to access was really critical. And then we could give them the phone and then we could contact them after that. There was also an enormous amount of activity that occurred in supporting people into TA, having their housing, health and other needs identified and supporting people out of the hotels into alternative housing arrangements. Would not have been possible without the sector rallying together, being flexible and supporting the redeployment of available staff. And it was amazing to watch. It was like there was so much goodwill, but I think one of the key things, that feedback loop where people could say this is an issue and there were people in the room that had the authority to make the change. People continued to push through and turn up to those meetings. So I'll hand over to Erin now for the health response.
Thanks, Jane. Is my mum like it? It is, yes, awesome. So I guess really what I want to talk about now is the health response. And I know arguably the biggest and most important health response was housing people in this time and keeping them safe. But there were multiple other health responses at play as well. And I think what we really focused on were also the people who weren't either eligible for TA or declined TA that were still left on the street. And we made sure that every single patrol, there was a health worker there, because we really acknowledged the need to support the health of those people as well. And often it took a little while and we would just consistently go out and see that person and they build up their trust, and then we would be able to provide them with TA. And it was really just making sure that we were monitoring people's health and getting them linked in when they were there. So I think the other thing is we also had peer workers, health peer workers going out into the street and engaging with people as well. And that was a really key response, and that really worked. It was really critical, to be honest. The other really sort of one of the first things that we established was mobile COVID testing. So the Kirkton Road Centre, which is an outreach initiative of the South Eastern Sydney Local Health District, implemented COVID testing in local hotspot areas and in social housing as well. So that was fantastic, but the original problem that we had is, where do you go if you get a COVID test and you're homeless? Because you can't return to the street. If you live in crisis accommodation, you're living in a shared facility, you can't return there. So yeah, it was a very difficult time trying to make sure that we had somewhere safe. And originally we actually had to admit people to hospital that were waiting a COVID test result. So not a great place. But luckily in July 2021, the special health accommodation pathway was established by Sydney Local Health District. And they were essentially like hotels that were set up as field hospitals. They were incredible, and they actually won an award for, last year in the New South Wales Health Awards, because the work they did were amazing. So people were able to go there for the duration of their isolation period, whether it be just until they got a negative result or for the full 2 weeks or until they were well. And it was full multidisciplinary support in the hotels, and people were often linked with social work and other supports in there as well, and would often feed people back to us after they needed to leave. So they would get linked in with our supports as well, and they work closely with DCJ too. Another really essential response, and I'm not going to go too deeply into this, but obviously we made sure that people had PPE on the street and in the hotels, hand sanitizer, information, did a lot of education, like I guess there was just creating awareness and specialised awareness around, use of injecting equipment, bongs, sharing cigarettes and things like that, and, the potential transmission risks through that, which obviously wasn't in the usual government guidelines that were distributed. So we made sure that, people were really aware of that. And the other really key thing too is there was a lot of services in the inner city that weren't government funded, and they really needed support. And originally everybody shut down and there was nobody getting any food. And then we really worked intensively with those services to make sure that they felt safe to reopen and provide people with food, and they had the education and support to do that. So that was a key thing. And I guess I'm just moving really quickly now to vaccination, which I feel like was a real highlight of our response. And so we started meeting as health agencies really early in 2021, and this was supported by the task force. So we had multi-agencies there as well to start planning how we were going to roll out COVID vaccines within the homeless community. And we really, when Pfizer vaccinations came to St Vincent's Hospital in May, we rapidly established our vaccination hub in Woolloomooloo, which is a hotspot area with a lot of social housing and people sleeping rough. And we made it as easy as possible to get a vaccine. We took away as many barriers as we could. So people could just walk past and pop in. Well, it's a bit of an exaggeration because the lines were so long. It was probably a bit of a wait after the first week, and people sort of word of mouth started coming. And you could get housing support there. You could get other health needs met. It was very much a supportive environment for people to come in. There was a lot of peer workers, Aboriginal health workers. We had a lot of different services supporting that initiative. And it was incredibly successful. So to this date, it has administered over 7,000 vaccines to people sleeping rough and in social housing. It was a difficult time though, because I think just remembering back to that time when vaccine access was at its peak of being the most difficult. And so it was challenging in terms of managing who could access them and access it and not. And we were getting a lot of pressures from other people to be able to come in. So it was quite a significant challenge to manage. So on the 12th of August, I remember this date very, very well. The first person tested positive to COVID-19 in TA. And I remember this so well because I still feel emotional about it because we'd protected people for so long. And we just rapidly stepped up the response. So one of the things that was most important was supporting the hotel owners, because we were worried that they were going to essentially just say, nah, had enough, we're going to kick everybody out. And so what we did is we rapidly, through the task force, worked really closely with the public health unit and set up a homelessness swab squad. And I've never worked so hard in my entire life, I would say, where we just were going in and testing and providing vaccination in the hotels. So really kind of like that concept of ring fencing as well, where, there's an outbreak and you vaccinate as many people as you can in that area. And yeah, it was a very, very intensive response. We worked really closely with DCJ and the hotels to make sure that people were safe. And it was really interesting. The public health unit gave us quite a bit of feedback. They said really the vaccination response, the early vaccination response actually really stopped the spread, very likely, and the amazing uptake of people experiencing homelessness. Of vaccinations, and also that, interestingly, when they looked at it from a public health perspective, it wasn't a building-based outbreak. It was a social network outbreak. So people were getting COVID in different hotels and in different locations, and were visiting different services, but they were all friends or engaging with each other for different reasons. So really interesting. And I think the other critical part of it was that the public health units realised that they needed a specialised response to our cohort of people because it was complex and there was a lot going on. So they formed their own complex cases teams. And that was really essential. We had a very close working relationship with them, and I think that really helped as well. So, and they came and would provide, sort of specialised guidance to the task force as well, which was really, really helpful. So, and I'm going to hand over to Tamsin.
I've gone backwards. There we go. So I got to put my glasses on because I've got to read numbers to you. Okay, here we go. So I'm just going to quickly talk to you about our achievements through the period that was really the first wave. And the first one I wanted to highlight was the actual task force itself. So it had 71 members across 24 agencies, and we often had 71 plus people attend each of our meetings, which, as Penny said, were held weekly, which was pretty awesome. I think that's a testament to the commitment, as Penny said, but also it was obviously the technology that we were all getting used to at the time, which enabled us to do that as well. So during that period, it's the 1st of April to the 30th of September, we oversaw more than 350 assertive outreach patrols across Sydney's inner city. Over 2,700 people who required TA were supported into the vacant and existing hotels, and that included more than 850 people sleeping rough. Shane talked about the pop-ups, so we had 82 pop-up housing and support hubs that were held at the hotels to offer the additional support. More than 240 people were provided with long-term housing, and as well as that, the support to maintain it, and that included 165 people sleeping rough. And then, as Penny said, we had thousands of meals that were prepared and delivered to the people in hotel accommodation. And I guess the other achievement to highlight, which you've heard a little bit about over the last couple of days, is Together Home, which was the housing program. So that was born out of task force discussions about accommodation pathways, ways that were needed, and what the successful elements or effective program elements of that should look like. So because we were able to draw on the success of existing policies and programs that were already up and running, we were able to stand up this Housing First model very quickly, which, as you probably know, was wraparound support connected to housing, and it also included a targeted Aboriginal response as well. And aside from what Erin's just said, in that first wave, we actually had no COVID infections recorded amongst people sleeping rough in the Sydney inner city, which was very good. So I guess following this first wave, the success of this first wave response, we actually had some time then to broaden our focus and start to plan for potential second wave, which we could see coming. So this included looking at potential responses for high-rise housing estates. We got into some collaborative risk analysis and problem solving as a group, as well as a planned transition to business as usual. And that was about minimising the impacts on the people experiencing homelessness, but also the staff who were supporting them. And I also wanted to mention that halfway through all of this chaos and frantic activity, the New South Wales Audit Office decided it would be a good time to audit our response to COVID-19, which was good and bad. I think one of the positives, though, was it was great to actually have an external body actually look at the task force itself and our response in terms of temporary accommodation, and actually highlight that as a really good success. So that was good. And one of its recommendations was to embed our learnings from COVID into our ongoing practice. So I'll hand back to Erin and she can take you through some of the lessons learned.
Super quick. So I guess despite this being a really difficult time, we did learn a lot, and we've really implemented some amazing things within the sector from it. I think really focusing on how, collaborative work is just so essential, and we can achieve more together than anyone in isolation. Also, in the feeling that you're in this together, I think creates like a sense of collective ownership and builds relationships. I think in just making sure that, I'm just going to quickly skim through this because I feel like there's some really key things I just want to highlight. I think just addressing homelessness as a housing and accommodation issue, as well as a public health issue to respond to the pandemic. I think that was really essential. And I think just the strong sector leadership provided stakeholders with the assurance this was important work that could be achieved better together. Just accepting what we had, what we could do and what we had no influence over. And really the value of that really assertive outreach, being persistent, consistent, building trust, showing empathy and being client-led. Wraparound support from health, housing and support agencies was really critical. And providing, culturally appropriate and responsive outreach services and support for Aboriginal people that were led by Aboriginal people, key. The voice of those with lived experience and informing service provision was imperative. We had people with lived experiences sitting on the task force and many of the care coordination meetings that we had. And also hearing their stories really inspired hope throughout the sector that things could change. And the importance of peer work, people with a lived experience being able to connect with people in a completely different way and building trust and enabling clients to take that leap of faith. Another sort of key learning was how temporary accommodation and being in those sort of nicer hotels really actually empowered people and built up a lot of people's living skills, which was quite an incredible outcome as well. And then also, many clients reported that it made a really positive impact on their mental health. Some not having had access to accommodation for many years. There were some clients that we took in that, burst into tears looking at the places that they were able to stay in. And that really created almost a sense of shame in me that, people, they deserve more, this and more, that's actually not okay that they feel that way. And so it was a humbling experience. And just removing barriers to access to services, streamlining housing pathways, creating options for verbal consent, implementing pop-ups, the wraparound support and access to vaccination. So really just trying to remove as many barriers as possible really works. Obviously, we know that. I don't feel like I'm preaching to the choir here. The importance of just remaining client-centred and relaxing the rigid policies, and that was really essential to COVID vaccination response. The flexibility, the technological solutions to hold large-scale meetings, which facilitated the immediate involvement of all services, and we were able to meet multiple times a day if we needed to. Which sometimes we did, especially in the Delta wave. Underpinning that all is how we have collectively continued to harness this knowledge and the relationships that we've built during COVID. And obviously we're going to be using this information and knowledge in the future and continue to build on that and improve.
So a round of applause for the presentation, but just a round of applause for the incredible effort of you guys. Well done. Sounds like, took every bit of passion and energy and applied it to your work, so well done for that. I might first go to a couple of the comments and questions online. We've got one question for the H2h team, and it's really for the whole panel, but we'll start with Tanya and Emilio and Mark. So the value of collaboration to deliver real outcomes is evident and impressive. What is the potential for all of this good work to unravel due to the time-limited housing, or the time-limited funding, I think is what is implied here? Yeah.
The potential is high. I don't think this microphone is working, but it's a huge risk to the program right now. It's a huge risk to people's housing sustainability right now, because and maybe Emilio, you can comment, but the work takes time to get going. Engagement can be really slow, of course, as we all know, and even the initial outcomes data that we've assessed internally on the SPDAT that Emilio was talking about, that when people have done the initial assessment and then a subsequent assessment, even though it's been limited in numbers, right now we're not seeing a change to improvement of health and wellbeing. And when you look at the data Mark presented around, comorbidity and, the complexity of clients, being housed for 9 months doesn't fix those problems. So, and lots of the housing didn't come until later on in the program. So it's a huge risk, and we will be advocating strongly to have some continuation for at least a portion of the clients who will often need lifelong support.
Did anyone want to comment from that from New South Wales? Maybe Shane?
Just rephrase the question.
So, you know, we've been funded to support people to access, stand up this support to access housing, whether through head lease models or through hard to lets or housing first. But the support is often only for 2 years. What now is, and what's the risk?
Yeah, absolutely. Even Together Home, great program. It was right at the beginning. We had to talk about what's then the next thing. And so I guess one of the working groups as part of the task force looked at a whole myriad of types of accommodation, which included things like meanwhile use, included rapid repairs and maintenance to other properties to step those up. At the end of the day, it's still an issue. It's like, unless it's perpetually funded and continues, and you continue to fund it, there's going to be people at the end of 2 years that go, well, what's next? And that unfortunately gets back to the issue of housing availability. So it's that one, yeah.
Questions that's online, and I'll just build on some of the points that were raised in the presentation today, was what are the implications for existing old style facilities going forward? And the question is around the old style congregate crisis accommodation. But I guess to add to that question and to reframe a bit for the panel, to bring in a little bit of that, but also ask, in consideration that 34 people, you noted 34 people were still to be housed, and you talked about the challenges around supporting people through what's often called the salt and pepper or spot purchasing model, the challenges with neighbours and engaging stakeholders, the challenges with people having to move multiple times in head leases. I think there's a lot of people in this room nodding and knowing that. Where is the space for the sector and us as collaborators to drive reform around the types of housing tenure? And what do you think the future needs to be to enable the conditions for that to happen? So if we know that some of these models aren't as effective for the types of people that really need ongoing support, what's the future for that, and where can we start for some advocacy?
Do you want me to start? Well, I think, Mark talked about the data on head lease, and tenancy sustainment has been the lowest in head lease housing. Not surprising. I mean, during COVID, in Victoria at least, everybody was working from home. So clients were under a much higher level of scrutiny for their behaviours than they've ever been before. So lots and lots of complaints. And head leasing is really expensive. It's very time limited, and community tolerance is low right now, I think. So for this cohort, in my view, and what our data shows us, it doesn't work. It's not a good option, but it works for other cohorts, like in family violence, for example. So it's horses for courses, I think. And even the salt and pepper mix, the spot purchase program was really fraught because of the type of housing that was purchased. But that's not to say that housing wouldn't be appropriate for other people. But when you're talking about someone who's been rough sleeping for 10 years and, putting them in a house alongside private residents who have saved, this is their first home, or they've saved all their life savings to buy this luxury apartment, it's kind of setting people up to fail, I think. And that's not to say that people aren't deserving of that type of housing. It's just got to be the right type for that individual. And, we're all challenged by that because there's just not enough housing, so there's no choice. But, yeah.
I'll just quickly answer that. I think in Victoria, there's a great opportunity at the moment as a result of the Royal Commission into Mental Health that has recently occurred. Recommendation 25 of the Royal Commission outcome does talk about an additional 2,000 supported housing homes for people with mental illness. 500 of them will be really specifically designed with lots of different types of innovation that can be utilised. And some of that will be and should be, I guess, not congregate housing, but I guess individual units that are together where there is still on-site support as well.
cluster or home and hub model. It's a model that's been applied across the country.
Yeah, absolutely. And I think there's some out of Ireland. There's actually some really good trauma-informed housing design guidelines that are being created, which housing agencies are thinking about and probably need to think about more as to how to really design homes that have some very subtle design features that actually take into consideration trauma that people have experienced, not just whilst they've been experiencing homelessness, but due to traumatic experiences that may have happened at other stages of their life as well.
Yeah, that's very interesting research, particularly for children of child sexual abuse. I've seen that, yeah. So one of the questions when we think about a group as, a group of practitioners in this room, and I'll put it to the panel and I'll go to the floor for some questions as well, is when we start to put ourselves in the position of reflective practice. We talked about the what today, and we talked a little bit about the so what. But one of the questions that I'm keen to put to the panel is, what now? We've had concurrent and ongoing disasters, across the country, specifically in New South Wales. We've had recent floods, fires, pandemic, and we've actually had plague as well in areas of significant mice population, damaging crops and agriculture and impacting local areas. Given all of this as a challenge for our sector and learning what we have from the COVID pandemic and the ongoing impacts, what now? How can we build resilience, and what are some of the things that you're putting in place in your services to make sure you'll be better set up for next time? Emilio.
Is it working? Yes.
Yes.
This is not exactly day-to-day practice stuff, but I think I got some thoughts on that. We were projected into a new world that we didn't know, and we were forced to learn. We've come out probably a little bit traumatized by that, but we've also learned a lot. And we've also learned what was not working and what hasn't worked during this time as well. So I think it's a great opportunity to take what worked and replicate it, learn from what didn't work and get away from that. It's as simple as that, I think. I might be, the last person that can comment on that, but this is from my perspective of what I've seen in the front line. Things like housing types, the ones that work, the ones that don't work. Let's not forget about it.
How can we capture that, maybe?
I was just meaning, I really wanted to comment, and it's a little bit different. I'm not going to talk to the housing approach because that's not my expertise, but I feel like the task force brought together what we were already doing. So then we just scaled up what we were doing. So it hasn't changed what we do, other than obviously we got access to more temporary accommodation for longer. But I feel like we're still feeling the effects of it. So we still meet multiple times a week now to coordinate outreach. We still patrol daily with the housing team. Or sometimes twice daily. Our vaccination response has expanded to the flu vaccination response, so it's, and then the other thing I think that's been significant was the Aboriginal-led component of it. So now we have an Aboriginal Community Services pop-up, and we have an Aboriginal Case Coordination Group. And so all that stuff we were doing before, now we're doing it better and we're continuing it. And I think that's really, but I'm not saying there's still not room to improve and define our practice in those areas, but I think it wasn't so much, obviously COVID was unprecedented, using the word, but we were able to build on what we already had, and we're continuing it.
I think, Trina, how we can capture it is by continuing to encourage government to invest in evaluation. And they have, in our case, in the From Homelessness to a Home program, and they also invested in an interim assurance review of the implementation process of this program, because it was at a scale that we'd not done before. So NOUS did that review, and Ahuri are participating in the evaluation. So, that's really encouraging, and we have to continue to be really about admitting what doesn't work and stopping it, and knowing that we don't have all the answers all the time, but just, really committed to continually assessing and adjusting.
Thank you. I'd like to put it out to the group today. Does anyone have any questions? Or reflections from your own services that you'd like to share for any standout lessons learned? Did anyone want to share anything there? Yeah, thank you very much. We might get you the mic because there's a good few people online actually for this session.
Sorry, Barney here. I think one of the reflections I had in listening to this, and also through sort of somewhat participating in some of the work in Victoria, is just first up the extraordinary effort. Like, I think, we can hear emotion come through in the storytelling up here, and we witnessed it every single day in Victoria, and that certainly played out right across the country. And I think there's a component to this which is around, how do we capture this? There's also, yes, great efforts to evaluate, but there needs, in my mind, to be some really significant recognition of the homelessness workforce right across the country. I think it's deeply under-recognised, and they're the unsung heroes of the pandemic response. We see great efforts to acknowledge emergency services, nurses, teachers, childcare workers, and that should absolutely occur. But I think homelessness workers are often sort of not properly understood. And I think the other, and this is probably more of an observation, the multidisciplinary trauma-informed practice that played out was just transformative. And I think how that can then be applied to the returning of rough sleeping populations in cities is where I would really hope to see some significant wins in reform, particularly in Victoria. So how can you model up the work in H2H? How can you apply that to street-based settings? And I thought that the comment around the NDIA and the NDIS, Centrelink have, tried to do this. They have outposts in different services. The forensic nature of an NDIS application means that your day-to-day housing worker just simply can't tackle, the beast that task is. So I think, the sustainment of these support models has to actually have Commonwealth support to recognise just how complex this work is. So I don't know. That's it from me.
Yeah. Yes, please. Yeah.
Look, just a quick one from me. I just think the collaboration and what we've learnt through the pandemic's been extraordinary. The sector's running ahead and not wasting the opportunity that the pandemic's given us. What's the level of courage across the sector now to push back on government to think about how it configures its funding going forward so we don't have programs running to the end where people are dropping off and cycling back into homelessness again? Because that's my greatest fear, that we lose the opportunity of the pandemic to make a dent, if not work towards ending homelessness. So this has presented a great opportunity. So I suppose it's a question to the panel, what's the level of courage that we have? But it's a question for all of us, really.
Absolutely. So I think it's, and that's a call to action. Thank you. And I think just to summarize our session today, what I'm hearing and I'm hearing from the room is, we had the evidence base, so we knew Housing First worked, and we knew working together in a trauma-informed way worked. So when the opportunity arose, we built on the networks that we already had in place to scale up and to meet the challenge of the day. But it sounded like, that needed bravery and courage and commitment. And they're all of the values and the skills that we need to take with us now through this next piece, this kind of some middle of after, because it's not over, but we're not where we were. So how do we continue to grow in an organic way as a sector to actually achieve this lasting change? So taking everything now that we've learned, building on that and applying that to be the new best practice, applying that to be the new way that we work and we operate. And so there's a couple of themes that are coming through that idea of being brave and being agile. And part of that bravery is about standing up saying, not this way. This way, we've learned the hard way, and listen to us and our expertise. I often talk to my colleagues in the sector to say, and extension to our colleagues in government, the sector is the entrepreneur and government is the investor. And it's about making sure that we can showcase the innovation and demonstrate what's possible with the right investment. And I think what we've heard today was an absolute, best practice example of that. So the call to action for all of us as practitioners and sector representatives is to be brave and have courage to continue that change and to take those lessons learned and continue the strength of the partnerships to continue. So thanks very much, everybody. We're right on time, and thanks for your participation. Thank you. Thanks, Penny.
Thank you.